Assalamu alaikum, everyone. Good morning. It's my privilege to present the first case of the day and start the case-based discussion today. So my case will be a TAV and TAV. I don't have any disclosures. So I hope through my case that we will highlight two important aspects. The first one is the importance of having or implanting your index TAVR valve in a right way to allow for future redo TAVR. The other important aspect that we will highlight is the meticulous CT planning involved in redo TAVR. Okay, we will focus on one important aspect, which is the new skirt and the new skirt height in relationship to the native valve anatomy. There are other concepts that are also important, such as the implant of the second valve and the depth of implant and the index TAVR valve degree of expansion, but we will not go over those aspects because we don't have time to cover all those aspects. So our patient is a 75-year-old female. She presented with severe aortic valve stenosis and then underwent successful TAVR in 2016. As you can see here, potentially the implant depth is at 4 millimeter to 5 millimeter. She presented 6 years later, unfortunately, with dyspnea and exertion and was found to have severe bioprosthetic stenosis. And the mechanism of failure is degeneration. And there's a significant calcification as shown by the arrow here on the CT scan. So we know that the TAVR volume is picking up. We know that we are doing more and more of intermediate and low-risk patients, and our outcomes are getting better. So we are going to see more of such cases in the future. So how is the redo TAVR compared to native TAVR outcomes? We have registry data. One of them is the SDS from Raj Makar, where they analyze propensity-matched cohort of patients, showing more or less that the clinical outcomes are the same. Although we have to take those kind of information with a grain of salt, because those TAVI implanters likely chose the perfect candidate for redo TAVR, and that's why we have good outcomes in such registries. So how do we select such patients for redo TAVR? One of the important factors that might affect our outcome is the coronary access, and mainly the risk of also coronary obstruction if we take that further. And to understand that, we will need to know the concept of neo-skirt. So what is the neo-skirt exactly? A neo-skirt is when you push the leaflets of the index TAVR valve, okay, aside with the new implanted valve in the redo TAVR procedure. So the leaflets will form kind of an endograft that is, or a covered like stent effect that might lead to jailing or compromise of coronary access or lead to coronary obstruction. And the neo-skirt height is usually the height of the commissural post of each TAVR valve. And that can be reduced if we implant the valve deeper in a self-expandable valve, but we're not going to go over that and leaving some overhang of the index TAVI leaflets. So if you have a self-expandable valve, such as in our case, we cannot put another self-expandable because you will end up with a really high neo-skirt. You will damage your coronary access. You can consider putting a balloon expandable and implanting it deeper. You will have a slightly shorter skirt. If you have an index balloon expandable, you can end up putting a balloon expandable in a balloon expandable or self-expandable in a balloon expandable with similar neo-skirt height. So these are the different platforms that we have in the market with their neo-skirt heights. And in general, self-expandable valves, they have higher neo-skirt heights compared to balloon expandable valves. So why are we interested in that subject? As we mentioned, neo-skirt can lead to sinus sequestration and lead to coronary obstruction as a secondary effect. So we need to predict that before we implant our second valve. There are multiple ways to understand that, and this is a simple example to predict that. So what we need to do is to measure the TAV inflow level to STJ. Okay, that will be your STJ height. For example, in this example, it's about 23.6. And then you want to measure the commissural level, and that will be your new skirt if you implant the valve. For example, we choose here a core valve as an example, or evolute. So if we implant at node 6, your new skirt will be 26. So here you have a case where new skirt is higher than the STJ. Okay, so if you have that, then you have to measure the THV to STJ distance. And if you get a number that is less than 2 millimeter, then this patient is at very high risk for sinus sequestration. So how do we protect our patient from that? We can consider surgical explant, but that is associated with really high risk of mortality. Or you can do a hybrid procedure. Some centers around the world, they basically do minimal cut. They remove the surgical leaflets and they implant directly a TAVR valve inside it. Or you can consider some sort of leaflet modification, such as the basilica technique that we know, to split the leaflets wide open and reduce the risk of sinus sequestration. Or consider using a dedicated device for such splitting of the leaflets, such as the shortcut device, with really appealing preliminary results that were presented in EuroPCR. But for that, for such procedure to happen, you will need to have a commissural alignment between your index valve and the native valve. So let's go back to our case. So now we are informed about the STJ height and the new skirt height for an evolute valve. So in our patient, the STJ height was 19 millimeter. If we implant at node 6, then our commissural height is 26 millimeter. And usually you want to implant at node 6 or 5 if you have a severe aortic stenosis as a mechanism of failure with degeneration of the leaflets, because you will left with some degree of obstruction. So in our patient, the new skirt height is above the STJ. Okay, so now we have to measure the THV to STJ distance, and our patient, unfortunately, is less than 2 millimeter. So our patient had high risk for sinus sequestration. So then we had to look for commissural alignment. Fortunately, our patient has a really great commissural alignment, and therefore the patient underwent double basilica and implantation of a sapien valve inside a 26 evolute with preservation of coronary flow. And you can see that the implantation was at node 6, eliminating all degree of stenosis. So I hope that this case illustrates the importance of first valve implantation. In the past, we really used to care about acute results, but now we are moving toward lifelong management of aortic stenosis. So we need to balance the implant height, okay, to preserve the patient from pacemaker implantation by implanting the valve a little bit high. But at the same time, we need to protect the patient or preserve coronary access in the future and allow for redo TAVR. So we have to implant the valve slightly, a little bit deep. So we have to have this kind of balance, okay, whenever we implant the first TAVR valve. And all of the self-expandable portfolios available in the market, we now know techniques to implant the valve in a way where we achieve commissural alignment. The balloon expandable, they are actually working on ways to achieve also commissural alignment with them. So in this summary, I hope that I've shown you the importance of index TAVR valve implantation in a correct way to allow for redo TAV or implantation by achieving commissural alignment, making sure that you choose the perfect valve and the perfect depth. And I hope that I've shown you the meticulous CT planning involved and the importance to predict sinus sequestration by measuring your new skirt height, the THV distance to STJ, as well as shown in our case. So before I end, I would like you also to refer you to this important applications, Redo Tab by Vinny Bappett. It's very nice application that takes you step by step in how to measure your, how to predict such complications and alarm you from potential complications. And even you can choose your implant depth and implant size based on your index TAVI portfolio. Thank you so much.